Hi, I'm Dr. Jared Christensen from Duke University and chair of the American College of Radiology Lung-RADS Committee. On behalf of the college and the Lung-RADS Committee, it's a pleasure to highlight some of the updates in Lung-RADS 2022. In this presentation, I'll be reviewing the concept of stepped management. Let's start by reviewing the management for Lung-RADS 3 nodules in Lung-RADS version 1.1. Following a baseline or annual lung cancer screening study classified as Lung-RADS 3, the management recommendation is a 6-month low-dose CT. If the lesion is smaller or stable on that exam, then the patient is reclassified as Lung-RADS 2 with a management recommendation to resume annual CT screening. Now, there's been some confusion over whether that meant 12 months from the current study or from the baseline exam. The original intent, as outlined in the first version of Lung-RADS, was based on the National Lung Screening Trial, and that was to obtain 12 months from the baseline exam, in which case it would be 6 months from the current study. Now you can imagine that some patients may not come back after their baseline study at precisely 6 months. Maybe they show up at 8 months, in which case you then have to count back and figure out how many months from their baseline for the appropriate follow-up recommendation. This means that when you're giving a Lung-RADS 2 classification, it may not be 12 months. You're going to have to figure it out. And so, for many reasons, adherence to this process and timing has been challenging in practice. In Lung-RADS 2022, we introduced the concept of stepped management, which simplifies follow-up. In this example of a Lung-RADS 3 nodule stable at 6-month follow-up and reclassified to Lung-RADS 2, the next annual screening low-dose CT can be obtained 12 months from the date of the current exam. Lung-RADS 2 is now always 12 months from the current study. There's no more counting back to the baseline. Now, in this case, stepped management means that the patient would be imaged 6 months later than they would have been in the Lung-RADS version 1.1 scenario. However, these nodules are considered benign with a less than 1% risk of malignancy, and modeling indicates that for the very small percentage of Lung-RADS 3 nodules that are cancers, the new stepped management approach will still allow for detection at an early stage. This, of course, assumes adherence to management recommendations. Now, some of you are probably thinking stepped management is great, but this is what I've been doing all along. And if so, well, congratulations, because now it's official. What about for Lung-RADS 4A nodules? What does that look like? Well, in Lung-RADS version 1.1, a Lung-RADS 4A, you would have the option of getting a PET CT if there's a solid component of 8 millimeters or greater. If that study is negative, you still can't downgrade it until you showed at least 3 months stability. So for all intents and purposes, we'll go with the scenario where the patient is coming back for a 3-month low-dose CT. On that study, if it's smaller or stable, then it's going to be reclassified as Lung-RADS 2 with a management recommendation to resume annual CT screening. Again, that would be 12 months from the baseline study or 9 months from the follow-up study. Now let's take a look at step management. So in stepped management in Lung-RADS 2022 for 4A nodules, it's really straightforward. If the nodule is smaller or stable at the 3-month follow-up, then they're downgraded or stepped down and reclassified not to Lung-RADS 2, but to Lung-RADS 3. So we go to the next lowest category. The management recommendation for Lung-RADS 3 is low-dose CT in 6 months from the date of the current exam, in which case the patient will then come back in 6 months. And on that study, if the nodule is smaller or stable, then we again will downgrade, this time to a Lung-RADS 2, and the patient is then to return for annual low-dose CT screening in 12 months from the date of that study. This is the concept of stepped management. And for Lung-RADS 4A lesions, this actually makes more sense because we're following these more closely. With in version 1.1 of Lung-RADS 3 nodule, we'd be bringing them back in 6 months, whereas with a 4A nodule, if it was stable, we would be bringing them back in 9 months. And so this is more consistent with our concern. Now, these scenarios we just walked through assumes that the nodules are stable or smaller and that no new nodules or anything else had changed. However, remember that the study should be classified and managed based on the most concerning feature. So if an existing nodule grows or a new nodule develops at follow-up, even if the original nodule you were following is stable or smaller, you should reclassify accordingly. So to recap, for Lung-RADS 4A lesions that are stable or decreased at 3-month follow-up, the management is going to be 6-month follow-up at low-dose CT from the date of the current exam because it will be downgraded or stepped down to a Lung-RADS 3. What about Lung-RADS 2? How does this work? Well, there's several scenarios, but again, a Lung-RADS 2 is going to be 12 months. The management recommendation will be 12 months from the date of the current exam. And so when would this apply? This is for Lung-RADS 3 lesions that are stable or decreased on their 6-month follow-up. It's for Lung-RADS 3 or 4A lesions that resolve on interval follow-up CT. But it's also for Lung-RADS 4B lesions that prove benign after an appropriate diagnostic workup, or 4B lesions that resolve on an interval follow-up imaging. So let's see some examples as far as how this works in practice. Here we have a case of a 10 millimeter mean diameter soft tissue nodule. It looks suspicious. Now you could get a PET CT based on its size, but in this particular case, again, based on the criteria, it was classified as Lung-RADS 4A, and they opted for a 3-month follow-up low-dose CT. So the patient came back in 3 months, and this is what it looked like. So it's, for all intents and purposes, stable, if not maybe even slightly smaller in size. Now, under Lung-RADS version 1.1, this would be recategorized as a Lung-RADS 2, and the patient would come back in 9 months from the current study or 12 months from baseline. However, with step management, 4A nodules that are stable or decreased at 3 months are recategorized by stepping down to the next lowest category, in this case, Lung-RADS 3, with a management recommendation to return in 6 months. This is, again, a more conservative approach, which is appropriate for these suspicious lesions. The patient here came back in 6 months, and this is what it looked like. So again, it is essentially unchanged. So now we're going to step down again from a Lung-RADS 3, and this study would be classified as a Lung-RADS 2 with a recommendation to return to annual CT screening in 12 months from the date of the current study. Let's take a look at this example. Here we have a part solid nodule with a 6 millimeter solid component at baseline screening. By Lung-RADS criteria, this constitutes a Lung-RADS 4A lesion with a management recommendation, in this case, of a 3-month low-dose CT follow-up. Now, the patient came back in 3 months and the nodule completely resolved. So at this point, you're not going to step down to a Lung-RADS 3 because the nodule isn't stable or decreased, it's completely gone. So the most appropriate criteria, again, assuming there's no new lesions and everything else is unchanged, is to reclassify as a Lung-RADS 2. And the management recommendation is to return to annual CT screening in 12 months from the date of the current exam. Let's take a look at this example. So here we have an irregular soft tissue nodule, 21 millimeters in diameter. Based on the size and composition criteria, this will be classified as a Lung-RADS 4B, or a very suspicious lesion. And for these lesions, the management recommendation essentially constitutes a diagnostic evaluation. And so in this particular case, the patient underwent PET CT, and we can see here that there's pretty pronounced FDG uptake. So again, very suspicious and concerning. This then led to further diagnostic evaluation with a CT-guided lung biopsy. In this particular case, 4 core samples were obtained from this lesion, and at pathologic evaluation, this was actually found to represent organizing pneumonia, so a non-malignant process. So this concerning 4B lesion has now undergone an appropriate clinical evaluation and found to be benign or not cancer. At this point, the management is going to be Lung-RADS 2, bring the patient back in 12 months. And that would be 12 months from the study where you have the last complete evaluation of the lungs with thin cut imaging. So the last time that you have a study that would be considered to meet screening technical criteria. In this particular case, that was the baseline study. Maybe your PET protocol includes full inspiration images, ours does not. So we went with the baseline study and counted 12 months from that time. Patient came back in 12 months, and this is what the lesion looked like. So it's even further smaller in size. All right, what are our take-home points? So ACR Lung-RADS 2022 introduces the concept of stepped management, which primarily applies to initial Lung-RADS 4A and 3 exams. For nodules that are stable or decreased in size, these can be reclassified by stepping down to the next lower Lung-RAD category with its associated management recommendation. For nodules that completely resolve or are proven benign after workup, you can reclassify based on the most concerning finding. And for many patients, that will mean reclassification to a Lung-RADS 2. And finally, a reminder that with stepped management, the timing of follow-up is from the date of the current exam being interpreted, again with that caveat, particularly when a patient undergoes a diagnostic evaluation, that it's from the time of the last complete evaluation of the lungs. So that is a brief review of stepped management and Lung-RADS 2022. These changes simplify management and we hope will reduce confusion for radiologists, providers, as well as patients. Thank you so much. I'd also like to thank the members of the Lung-RADS committee who have contributed significant time and expertise for these important updates.